Hi, and welcome back to another episode of the Healing Medicine Show. The vision for this show is to provide healthcare professionals with resources and inspiration for both personal and professional development practices, especially those that are rooted in holistic health. We believe that the change in healthcare starts by focusing on the health and the healing of the healthcare providers. I'm also very excited to announce our own 2024 Health Women's Wellness Retreat for healthcare providers, February 3rd through the 10th in Costa Rica. If you're interested in joining us for a week in paradise, check out the link below for more information. So today, to kick off November, Men's Health Month, Movember, as some people refer to it, we are sitting with author and retired physician, Dr. Vicki Monlog. Dr. Vicki has been in practice for 35 years. She has combined traditional medicine with alternative medicine, that moving into regenerative medicine, which we'll get her to explain, and then finally into bridging into energy medicine, which is super fascinating to me. You've heard us talk about the different modalities of medicine, complementary and alternative modalities. It's something that is near and dear to my heart as we move modern medicine forward to begin making a bridge between the Eastern modalities of healing and the Western modalities of healing, and creating something that is unique, new, and innovative. There's also, in honor of Men's Health Month, a CE that's happening at functionalmedicinece.com. It is a functional medicine focused CE for healthcare professionals, and they will be discussing lots of men's health practices. So with that being said, I am so excited to welcome Dr. Vicki Monlog. And Dr. Vicki, I want to start off this Healing Medicine Show interview by asking you the same question we asked of all our guests, which is, what does healing medicine actually mean to you?
Healing medicine, and that's a great question, is not about this is the protocol that I'm supposed to follow, therefore here is my playbook. And, oh, you don't fit my playbook. Oh, well, I'm sorry, you must be doing something wrong. And turning that blame onto the patient where you may not be correct in what you're trying to work with that patient with. So, a patient is aware of what their symptoms are. They're aware of what is not working for them. It is our job to help interpret what they're trying to tell us into what really is happening. But too many docs in the world are told, you can't do this type of testing. You can't do hormone testing. You can't go down that direction. You have to stay within these narrow walkways of what you can test. And by the way, you have a quorum of how many patients you need to see. Here's the time frame you see them in. And, oh, you haven't done enough testing. And there are all these requirements that healthcare providers are put under that the general public is really not very aware of. And it hamstrings and ties hands behind the back of many healthcare providers.
Absolutely. And I think that idea of sticking to the playbook, of being afraid to think outside the box, has actually stalled the innovation that we would like to be seeing in modern medicine. I always say, as a pharmacist, I have a very healthy respect for all of our pharmaceutical medicine technologies. But because of that respect, I also realize that there are other opportunities. And I think that's what patients are really looking for. That's what I'm hearing from them, is they're looking for other options. They're looking for healthcare professionals that are willing to, admit that the patient is actually the expert on their body, and we're there to support and guide them through that. So I want to hear a little bit about your own, personal health journey. How did that inform, as you were changing from a traditional medicine practice to complementary and alternative to regenerative to energy medicine? Usually that, as attendees will hear on this show, that's spurred on by our own personal journey. So I'd love to hear what kind of sparked your interest in different modalities of healing, and how did your professional career kind of mirror your own personal journey?
Well, it's kind of a long answer, so bear with me. When I first started medical school, in my first year, had a ruptured appendix, which ruptured into an abscess, which nobody believed me that my symptoms were real. They knew I had a fever of 103.5 and peritonitis, but they kept calling it other things and bringing different specialists in to check me out. And I kept telling them, isn't this potentially an appendicitis? No, 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 couldn't be. And they kept giving me all the reasons that it wasn't, but yet in the end, I ended up having it rupture during the middle of a breast lecture and disrupting the whole class, ending up getting taken to the hospital through the tunnel from the medical school to the hospital, being admitted and emergency surgery at 10:30 at night while I'm going into shock. And the chairman of the department is going to operate on me, right? It's the big show. The chairman is going to take care of the medical student. So as they're wheeling me down the hall, he says to me, do you have any questions? And I said, yes, I do. I said, why is my diagnosis a ruptured ovarian cyst with torsion, twisting, when I have a fever of 103.5 and peritonitis? That doesn't fit. And he grabbed my hand and he went, now, dear, that's why I'm the staff and you're the student. Never forgot that. When I woke up 36 hours later, what I found out is that not only was it the ruptured appendix, I died on the table. They had to bring me back. They had to call in a general surgical team to clean up what GYN couldn't accomplish, because they went in with a GYN diagnosis, made the wrong incision. General surgery had to come in, work through the wrong incision. And like I said, I died on the table and they brought me back. So when I came to in the hospital 36 hours later, there was a representative from the medical college sitting at the end of my bed. And I thought, oh, isn't that nice? They came to check on me. And he straightened up and he fixed his tie and he goes, I'm here to inform you that you've missed your exams and that you'll be getting an incomplete until you have all of your exams done. Do I make myself clear? I've got NG tube, dual IVs. I haven't even seen the surgeon yet. My original dressing is still on. I couldn't believe it, that this is how medicine was treating its own. And I almost quit medicine. And I thought, no, there's a lesson here. The lesson is you can change this. So when I first went into practice, I was the traditional OBGYN that I was running 2,000 miles an hour with my hair on fire and delivering those babies, for my hospital. And I was president of my organization, my group of independent docs. But it just wasn't, it wasn't there. I had put a women's wellness portion into the clinic. And we were doing retreats for women on a yearly basis and going to different locations and bringing all of that education to them. And my partners called it fluff. And I said, do you guys not get that wellness is what patients want? Yeah, but that's not what we want. We want more procedures, more money, more surgeries. And I went, no, I can't work with you. So I left and I went solo and I did traditional medicine for a bit, but I was seeing the patients that nobody else was helping. They'd come in and give me their list of complaints. And it was hormone imbalance and hormone deprivation. And because it didn't fit into, oh, you have this symptom, we have this pill to fix it, they weren't getting answers and they weren't getting the help they were looking for. So when hormone balancing helped them, they started bringing in their husbands. Can you do this for him too? He's got a lot of the same symptoms. So that's what brought in a lot of the modalities of alternative medicine, because traditional medicine just wasn't cutting it. And so alternative medicine did so much more. And I brought trigger point in, and I've had a chiropractor in the office and acupuncture. And we did a lot with a referring dietitian that we did very close work with. And I had a gym and exercise physiologist that we did a lot of back and forth consultation with. So it was this moving group of professionals that almost all of my patients were able to hit. And then when regenerative medicine came out, originally it was called stem cell medicine. Well, that became very obvious that it was not so much the stem cells, it was the proteins and growth factors that these stem cells made So instead of injecting cells, which was very expensive, you could inject their proteins and growth factors, which initially were called exosomes. They're now called placental amniotic fluid products. Those proteins and growth factors are what do all of the regenerative work. So you can inject a knee, for instance, that has a complex torn meniscus that an orthopedist won't even touch. He'll say, I can't deal with that. And you can put one dose of proteins and growth factors in, and you've got them walking without a brace. This is my husband's story, in 2 weeks. And he was mountain biking in our park in 3 weeks. And I won't let him run because that's what got him in trouble in the first place. He was a marathon runner. I said, no, your days of running are over, but he can bike and he's doing everything without a brace. He has no knee pain, hasn't since the 4 weeks after the injection. So that's powerful when you realize that you can give people back the ability to heal something torn. And then beyond that, energy medicine. And energy medicine is the up and coming way of stimulating the body's own mitochondria on a cellular basis to work at the higher energy level of 75 to 80 millivolts, which is the energy level of a 20-year-old. So what if you could actually charge your body back up head to toe to work at the energy level of a 20-year-old? Wow. Knowing that cancer can survive only at 20 millivolts or less, and you can raise your energy back up to 75 to 80 millivolts, you can fight your own cancer. You can help fight your own MS. You can fight any disease entity or diagnosis that you may have going on because your body is working at a higher energy level and you're simply giving it that charge. You're not taking a chemical for it. You're not doing anything surgical for it. It's simply energy.
I love that. You said there were so many golden nuggets in there. One of the things you said about healing, you talked about the healing the meniscus, healing something torn. And this idea, this is kind of what healing medicine means to me, is that we're not giving band-aid fixes. We're not giving you, medicines that you're going to have to take the rest of your life. What we're doing is focusing on what does disease reversal look like? What does removing the offending agent, whether it's, food related or tissue damage or normal aging processes, how do we reverse those processes and conditions to actually repair and truly heal the body? And in the very beginning, you talked about this idea that our business model in healthcare is we only get paid if we keep people coming back, right? So there hasn't been a huge focus on preventative or healing medicine to this point. And, me coming from the pharmacy world, it's bad for business, right? We get paid by refills and we get paid by people coming in. So there's, to me, this real conflict of interest that is happening with the corporatization of healthcare. And for those of us who are, who have really stepped into our own healer identity, the medicine woman identity. I told you before we started recording, I have a friend that calls me the medicine woman. And I love that. I fully take on that idea. But those of us who are open to other modalities of healing, and we're seeing those results, not just anecdotally, because I think, in addition to the conflict of interest being there to say, oh, we're not making money by healing people and so that they never come back, there's also this idea that that these things are unstudied, and that's something that I will play the devil's advocate, that people will say, well, we haven't seen the studies, show me the studies, show me the clinical trials, show me all of that, because that has been a huge part of our conditioning and training in school is to look for the evidence. When the evidence is being supplemented by pharmaceutical companies, and there isn't a lot of money behind these healing modalities, there's less evidence besides anecdotal and personal experience. So it's kind of like the chicken and the egg. As more and more healthcare providers, and that's the purpose of this show, to give resources and inspiration for people to continue on their own healing journey. I think as we heal personally, we can pass that healing along to our patients, as experiential. I've experienced this for myself. I've experienced what it feels like to have more energy, to have more vitality, to be able to heal, to not need, pain relievers for my knee for the rest of my life. So I think that's really powerful that we can experience this for ourselves. So I want to kind of transition, because it is Men's Health Month, and we think, men's health, we think ED, erectile dysfunction, is kind of like the main reason, the chief complaint that we would hear in a men's health talk. But testosterone is so much more. And so you have a couple myths and truths about testosterone that I would love to dig into. So I kind of want to start by just asking, in your opinion, what is low T? How do men even find out? How does it change as we age? And what are maybe some symptoms that people should be looking for?
And that's what drives the patient finally into the office, is they won't come in and say, I have ED. Unlike the commercial where the guy walks into the elevator and says, I have ED. That I don't know any guy that would do that, number one. But that's usually not the reason they come in. Their wife is the one that sends them in. Probably 70% of the time, 30% of the time, they come in on their own, because they've gone maybe to their primary or to their ND and asked for their levels to be drawn. And medicine will usually only check a total testosterone, but not the bioavailable free testosterone. And they will tell them, oh, you're in normal range, so you're fine. Well, that whole thing is a myth right there. Understand that labs are drawn and the normal range is given for every 17 or 12-year-old up to 90-year-old. That's the range that it's put in. So what is completely ignored is the fact that there is a degradation curve that goes along with testosterone. And that degradation curve is able to be graphed. And so for purposes of showing you a very easy to see, but it takes you out to age 100, that's called age appropriate testosterone. In other words, it's not whether you're in range, it's are you appropriate for the range for your age. So when a gentleman would walk in and show me his total testosterone, I would make him redo it for a total and free, but I would show him, okay, if your range, is here to here, but you're at 40 years old, you should be at approximately, and I'll just look at my graph, you should, for a 40-year-old, be at about a 68th percentile for your testosterone, and his would show 20th percentile. Well, that's too low. You're doing more at age 40 than what a 90-year-old man who would have a 20-year-old level would have. So that's a disconnect. And once they realize that there's a difference between normal range and age appropriate numbers or range, then they start to understand that there is a difference. And then when you realize that there's total testosterone, free testosterone, the bioavailable may pull from the reserve of the total so much that the total gets really low, but the free T may be appropriate until you keep dropping it, and then they're both too low. Then that's somebody that's going to walk in with a lot of symptoms. So it's not, do you have it low T or not? It's, are you age appropriate, and where is your utilization of your reserves to pull out your bioavailable? And is your bioavailable where it should be?
So, I think that with testosterone, you mentioned other symptoms, and there's a lot of other symptoms besides low libido. So what would you say are maybe some common symptoms of low T that may be misdiagnosed in other things that could be that the low T could be the main cause of, that we might not actually think about as being related?
Two that come to mind immediately because they were common in most of the guys walking in were that deep bone to the bone fatigue, where they would come home from work, sit down on the couch, and just fall fast asleep. Hard for the wife or the kids to wake him up. And, he started getting the reputation at home of being a slug because he wasn't able to contribute to anything going on in the family. He'd go to bed, wake up just as tired as when he went to bed, getting anywhere from 12 to 16 hours of sleep, but still bone tired. That's one, because your muscles are just not getting that rejuvenation that they need. Another one is actually a depression. When guys start to get a little angry or they get depressed and they're not participating, it may actually be low T. And it's not really a depression, it's low T. Another really favorite one is ties to the GI tract. And it again goes back to muscle, but GERD. And think of the fact that at the base of your food pipe, your esophagus, there's a sphincter there. That's a muscle. And that muscle has to stay tight to let the acids and the food stay in your stomach versus come back up in reflux or gastroesophageal reflux or GERD. And so if you have low T, you may actually have a weak sphincter for your age and physical conditioning. And you may actually have GERD out of proportion that any medication isn't necessarily covering, because it's not about just neutralizing the acid. It's about strengthening the muscle of the sphincter. And that part gets forgotten. Heart palpitations is another one. Again, what is the heart? It's a muscle. So a lot of things go tying back to the simplicity of things, but headaches and migraines are many times low T, because think about the multiple potential causes of migraine, and many of them are muscular. Whether it's caused from TMJ, whether it's caused from tension in your neck and in your shoulders, whether it's chemical related. There are many, many reasons, but low T is another reason. The actual hair loss that guys go through, the weight gain in their belly, we always attribute that to an older gentleman. Well, you drop their T to the level of a 70 or 80-year-old man, and guess what? They're going to lose their hair here, and they're going to start to get that, what we call a Milwaukee tumor, which I live in Milwaukee, so I can say that. But you start getting that belly, that beer belly, and it's low T for a lot of guys. It's not that they have poor dietary habits, although they may think, well, as long as I've got the beer belly starting, I might as well just own up to it and do it. And that's not necessarily then the cause, it's an after effect. So many symptoms can masquerade as low T.
I love that, that we think of low T as a sexual dysfunction, and you have really changed my mind to now think of it as muscular dysfunction.
Very much so. And we have muscle everywhere. And it is supported by our collagen and our tendons and our cartilage. Everything ties, but we have muscle from head to toe. So every part of the body is potentially at risk.
I love that. You've also written several books about women's health as well, Blossoming as well as Full Bloom. I'd love for you to just talk a little bit about those two books, and where can people find more information about you and about your work?
Well, and thank you for that plug for my books. I started writing Blossoming first, my adolescent book, because they are the forgotten female. Nobody pays attention to the adolescent. What do we call them? Drama queens. They get PMS. They've never experienced it. They're grappling with the whole idea of hormone swings on a monthly basis. And we as moms are busy with our job, with taking care of the rest of the family. And we don't have time because we went that journey and we figured it out. So our assumption is they'll figure it out. Well, what they do when they get sent to their room for being a drama queen is they go on Dr. Google and they start finding out what they can find out. And that's not the source that you want. So you've now turned the mother-daughter relationship into an adversarial relationship. What it should be instead is mother-daughter enabling and empowering each other to get the correct information. So a lot of adolescents are sent to the pediatrician who has no clue what to do with, take a simple, I have cramps. And the pediatrician goes, I'm used to shots and baby checks, and are you on the growth curve and vaccinations? And oh, well, we'll just put you on the pill, and that adolescent had just screwed up all of her courage to actually ask the question, and she just got dismissed and told her question was not worthwhile. It doesn't deserve my time. Therefore, let's just put you on this pill and we'll talk later. Well, that's not going to come up later. She's not going to try that again. So the mom and the daughter really, the book was written for them to be able to explore what are the symptoms that the adolescent daughter is going through. And it's more than PMS, because just like male hormone head to toe, so is female hormone head to toe, but they also have to contend with male hormone in addition. And so polycystic ovary starts, but it starts very slightly in adolescence, but it escalates. And by the time it's strong enough to show what it's truly doing, may be some significant morbidity going on. So that was the reason for blossoming. The second book, Full Bloom, is written for their mom, or what I say for my generation. And that's the 40, 50, 60, 70, 80-year-old who are told, you've delivered your babies, I've done your hysterectomy, I've lifted up your bladder, there's nothing more I can do for you, get out of my office. Wait a minute. So that's number one. So many times women are dismissed from the GYN's office at about age 50. And you still are going to live 20, 30, maybe 40 plus years more. So you're going to spend as many years without your natural hormone as you did with. And so for those years that it was so valuable for you to have your family and for you to have, your health, then it's suddenly so bad for you when you hit 50, just because your body stops making hormones so you can't have babies anymore. Does that mean the rest of your body should be deprived, muscle, joints, everything else, of that healing hormone that our body so beautifully made for us before? Modern medicine gave us the ability to live longer with many of its breakthroughs, antibiotics, safe surgery with anesthetics, and, many things that really helped. But it didn't change the evolution of, we went through menopause at age 50 and a half. That's the average age of menopause. And that's even going back to 1912. So that isn't caught up with where medicine has taken us. Guys continue to make their testosterone. There's no break in them making it. Even at age 100, they make 20% of their testosterone. Wow. That's crazy if you think about it. So my books, I'm writing the 20 to 40-year-old for all the diagnoses that happen to those women. And then the men's book is also in the queue. So they're all on my website, which is my name, Victoria J. Mondloch, MONDLOCH, MD.com. And the listing for Amazon in the books is right there.
Absolutely. Thank you so much for sharing that. And I look forward to that book. I've had my own challenges with infertility and, in pregnancy and postpartum depression and all of those things that come along that, that are struggles. And, my story, I think I shared this whenever I went into my OBGYN office and shared that I was having trouble getting pregnant. And, I said, I don't know, maybe I have PCOS. I had some, extra belly fat and like some different things that I thought, maybe this could be a symptom. And he took one look at me and said, I can tell by looking at you, you don't have PCOS. And I'm like, maybe I'm shaving my mustache. Like you don't know me. This is the first time you've ever met me. And so it's just instantly here, take the Clomid, take the fertility medicine. And, I always kind of wondered like, was there something else going on? And then after I had my kids, my second child, he was born with pretty deep sacral dental that it was not an open neural tube, but it was pretty close. And I really, that's when I started on my own health journey. And I took a, genetic test. I found out I have this methylation mutation. So I'm not able to methylate folic acid. So like that kind of made sense. And then I've got, Parkinson's and Alzheimer's dementia on both sides of my family. And that's linked to the methylation issues. And so once I started getting my methylation issues under control, I started changing my diet, drinking less alcohol, meditating more, spending more time, moving my body and doing yoga. So many other things started falling into place in my health. And so, it's, I talk about kind of the breakthrough, the breakthrough drug or the breakthrough moment in our own personal health journeys that kind of opens you up to these other ideas. So I wanted to say thank you so much for your advocacy, for truly innovative ideas about how to run a practice. Thank you for sharing more about the symptoms of low testosterone for Men's Health Month. And we want to encourage the men who are listening to really, make sure you're getting your check-ins and getting your screenings done this Movember. And I have a dear friend that is a survivor of testicular cancer. So it's very, very meaningful to me. So we'll link your email or your website, VictoriaJMonlockMD.com, in the comments below. And Dr. Vicki, I just wanted to thank you so much for joining us here on the Healing Medicine Show and for sharing so much wisdom with us.
You are more than welcome. It was my pleasure.